you know, making it out this far, and also for participating. And I'm glad that we also have a good quorum here virtually and in person. Our goal really was in the end, again, to make this much more of a, interactive session. And also, again, to highlight really the work of, the House staff and trainees here and nationally, who did such a great job of kind of creating some cases that I'd like both trainees and faculty to kind of go over in an interactive fashion and hopefully generate some discussion on kind of where we see ourselves in the whole spectrum of, being able to make sure that we are being able to deliver the most equitable care for our patients, especially in the city of Los Angeles and beyond. So I will introduce all our presenters momentarily, but I wanted to just give you some background for what this initiative is all about. So, a setting essentially this is an ongoing initiative between the ACC Lifelong Learning Oversight Committee and the ACC Education Committee and the ACC DEI Committee. And, I actually heard about this opportunity through being an alumni of the Cardio Oncology Section Council of ACC. And with, Olu's generous availability, as well as with Dr. Chung at the EP group, we also basically were asked to provide some didactic case exercises, which essentially will hopefully be online eventually on this health equity focus-based course, which are case studies designed to, test your knowledge about, treatment gaps and healthcare, disparities in care in very practice settings and patient populations. It's not really so much necessarily these exercises are geared for how you treat cardiovascular disease, but also really focusing on which treatments are perhaps the most optimal and most equitable, and how do you get the access you need to care for these patients. So it's a really much more of a non-traditional approach to cardiovascular disease, but I think really that is a real world approach to how we really should be addressing, patient care, or at least being aware of what our own biases can affect, clinical care of these patients, as well as how we, how we can provide this in different healthcare settings. So again, a quick introduction to all of our staff of our presenters. We have Dr. Olumuyiwa Akinrimisi, who technically is not a fellow yet, but will be in 2 weeks at Stanford. Omid Amidi, one of our outgoing fellows, who will be joining a cardiology group up in Lakewood in the Burbank area. Dr. Christopher Berg will be joining one of the big Orange County groups down south. And Dr. Ynalvez, who is our guest of honor today, coming from UT Houston, who is a second year, who will be doing her chief year in a couple of weeks too. So I'm especially grateful, given how I operate, that I literally grabbed all these people like 2 weeks before the due date and said, hey, you want to do this? Great, you got 2 weeks to do it. So, because like a lot of section councils, we were all told about this opportunity last minute, but we had a lot of cases I thought were worth highlighting from that standpoint. So, and also more important, also just a big thank you to the ACC mentors who were available for this nationally. Dr. Anita as well, who actually let us know about the opportunity, who is the chair of medicine over at MD Anderson and cardiology, and Dr. Ming-Hui Chen, who's the director of the Cardiovascular Health Cancer Survivors Program. She's a pediatric cardiologist at Boston's Children's, and Dr. Jim Chung, who's director of EP research over at Cornell, New York Presbyterian. So really topics covered. Now, they might, on the surface might seem cardio-oncology and EP related, but ultimately in the end, these are actually very fundamentally straightforward, cardiac concepts, but really within the unique bent of focusing on, how are specific vulnerable groups, as well as, specific, whether they have limited access to care, or what can you get them the tests and treatments they need. And also at a certain degree, as Chris's case will show, can certain approaches to diagnostic, disease states and treatments can also essentially, unfortunately, affect your bias or clinical judgment of what's going on. So before I begin this, I want to reemphasize again to go to Kahoot to sign on. This is really critical, and we'll do some just quick test runs here. I'm going to share my screen really quickly. And see here. So make sure you sign up on some of the names here. Don't worry, you will be anonymous. And I put the link in the chart just to make sure again that you have, sign in on your smartphone. Just put your names here. You could be anonymous. And don't worry, the questions that you answer, no one will know what you answered and picked. We just want to see what everyone says or does. So Great, Bobak. Awesome. Putting it out there, being proud of you are. I like your emoji. Okay, we're gonna get started with some quick things here. So just as an exercise, I'm turning off the annoying music, don't worry. So really quickly. So just really so the countdown. So this will be a word cloud exercise. Please list barriers that you feel lead to health inequity. So please type, you only get one answer. So this is just to get an idea of what you see. You got 10 seconds. It's finance, social economics, insurance coverage costs. Great. Excellent. I mean, I know this is obviously a very complex question, obviously. So, but I think that, this is definitely something that the COVID-19 pandemic has put in the spotlight. And now the ACC really wants to highlight. And I think it's really important that we more systematically integrate this into, also house staff education as well. Now, here's a quick poll as well. What is your current position? So you got 10 seconds because hopefully you know what you're doing. So, 3, 2, 1. Hopefully the interface is pretty easy.
Neuroscience practitioner.
Sorry, that was so mostly fellows here. That's great. Risi practitioner, actually, exactly. Oh, so my bad. So I'm going to go back to here in a second. Go back. My apologies. I know. It's so bad. This is my problem. I'm really bad at this. So, anyways, you know what? We'll just hold this for that second here and stop. So, all right. Now back to the screen here. We're going to give first. Oh, I did. Okay. First, give the screen back to Olu here. So why don't you first start with your case here?
Yes. Hope you guys can hear me well. Yeah, my name is Olumuyiwa Akinrimisi. I'll be talking about symptomatic premature ventricular contractions management in a non-adherent patient. I work alongside Dr. Eric Yang and Dr. Jim Chung. Again, thank you all for this opportunity. So we'll start with some of the learning objectives. So take into consideration a patient's socioeconomic circumstances to improve medication adherence in treating PVCs. Understanding all stages of pharmacologic and non-pharmacologic options for symptomatic PVCs. And lastly, pharmacologic and procedural approach in managing PVC-induced cardiomyopathy. The chief complaint, a 44-year-old Latino man presents to clinic with frequent palpitations. So the HPI notes the patient has been reporting palpitations for the last 2 years. His first palpitations came on sporadically once every week at rest or with exertion and will last just for seconds. Over the past 4 months, he's noticed it being a little bit more frequent, denies any syncope or chest pain, drinks glasses of wine nightly, does not drink coffee, doesn't use any herbal supplements or energy drinks. He does have 2 labor-intensive jobs, denies any overwhelming life stressors. He denies any history of anxiety or depression, prior smoker, but quit 10 years ago. Patient is referred to cardiology by his PCP for further evaluation. And when he presented to the PCP, he endorsed the symptoms of palpitations. He reports they have been occurring almost every day, randomly, and are not related to exercise or rest. They never used to bother him, but he is now concerned about the frequency, denies any shortness of breath, chest pains, or any syncopal events. And then some additional history. So history of hypertension, sleep apnea. Father passed away from unknown cause, but had a history of hypertension. He is married with 3 kids, lives in Central California. His insurance is Medicaid. Again, he has 2 labor-intensive jobs as a textile factory worker and a scrap and junk collector. So pertinent physical exam findings, just hypertensive at 145/82. Heart rate is within normal, but slightly a little fast at 98 beats per minute. Physical exam, nothing remarkable there, so pretty much normal exam. And as far as the EKG at this moment showed normal sinus rhythm, 83 beats per minute. QRS morphology was normal, along with 430 milliseconds by Bassett. Again, patient was asymptomatic at this time of this study. So starting with question number 1. So what is the next best diagnostic test? Exercise ECG treadmill, 14-day ambulatory ECG monitoring, TTE, wearable wrist heart monitor like the Apple Watch, and a 24-hour Holter monitor.
So I apologize heavily. So unfortunately, I didn't know how to restart the question. So we're going to start again with a new link in the Zoom box. Please check on that again. And we're going to start going down the line here. And just look at the answer really quickly. Grab the bite to eat, and we'll get started here. So sorry again for this. I promise it won't happen again. Sorry, Olin. So,
Something we're supposed to be pressing.
yeah, go to the new, you go to the link here, and then, yeah, well, you can talk about it if you want.
You can talk about it.
You can talk about it.
Where's the link again?
It's in the Zoom link. It's in the Zoom chat box. Yeah.
Join the Zoom.
Yeah, join the Zoom, please, and I'm going to share my screen now. Yeah, exactly.
While we're here, we have.
There we go. Sharing screen. Here we go. Get ready. Here's the what's in the sentence. Okay, get ready to vote, everybody. Okay.
Too much for me.
30 seconds.
Only 30 seconds.
30 seconds. It's like a boards question, right? So
Clinical lens as well as health equity lens. Answer this.
7 answers.
Can't you do more than one?
Well, of course, but the thing is, you got a limited resources, right? So,
Medicaid?
oh, so this is interesting, Olu. Everyone said 14-day ambulatory ECG monitor.
I predicted.
I don't know about that.
Exactly.
He said he had symptoms during the EKG, which was normal.
Normal. No symptoms during EKG.
Well, he said he was symptomatic at the time.
Did you say that?
No, yeah.
Switch it back.
Yeah, switch it back. Yeah. Switch back. Sure.
Symptomatic meant to be asymptomatic.
It was he's been symptomatic almost basically every day.
Yeah.
So go back to this. Yeah, there we go. Okay. Okay. Okay, next.
All right. So.
You have to click on it and just let him.
Oh.
On the,
Technical difficulties.
go ahead.
Perfect. So in this situation, answer C would be the best answer choice. We don't have to say correct, it's just more correct. Other answer choices can also be very reasonable. And kind of breaking it down. So again, the EKG was normal in clinic. However, the patient notes that he has palpitations occurring randomly and daily. The best next step would be some type of ambulatory cardiac monitoring. And most of you guys picked B, which again is a reasonable answer choice, especially when you're looking at it clinically. Given the patient does work 2 physically demanding jobs, during the week, it's important to consider the best device to monitor his heart rhythm. So his jobs are pretty extensive, and with the 14-day monitor, it doesn't stick that well, just like the little social implications where it can slip off. So that's something else to consider. So he's fairly busy. The 24-hour Holter monitor is a perfect option just simply because he can just wear it on his day off. So he can wear it on for 24 hours, stick it on, and because the symptoms occur daily, we should hopefully catch something. And the other thing, looking more in the health equity lens, Holter monitors are typically covered by Medicaid, which may not cover the 14-day ambulatory EKG without an additional Holter.
Yeah.
That may be out of pocket for this patient.
I know all of you now, they do prescribe Zio patches, and again, it also has to do with local county contracts, but it's important not to just assume that most, like device companies necessarily are available. And I think it's also important, again, for a period of time, LA Care, you couldn't get Zio patches. They were only contracted with BioTel. So it's really important for wherever you work that if you do have a Medi-Cal Medicaid patient, to ask kind of your local offices and practices, like what are the local practices. I mean, this is a bit of a general statement, but I think this is a very important thing that what's the most high yield? Thankfully, it's daily, right? If it was a little bit like once in a while, and we got a little bit, it might be a little bit more challenged. It's really important to realize that we've had a lot of patients that because of the day job, they just could not set it up, or in some cases never wore it because they just weren't able to get to it, some of these symptoms. So
these are some of the learning outcomes. I probably won't go too into detail, but just things to highlight here. Again, like this patient in this case who has poor access to care and adherence, it's crucial to choose the diagnostic modality centered around the patient's social circumstance. So kind of this targeted approach that's very unique and specific to this particular patient. An important aspect to consider duration of therapy, ease of use, cost, as well as insurance coverage, which Dr. Yang alluded on. All right, so this is the next kind of problem. So the patient was prescribed a 24-hour pulse monitor. He wore it during his day off of work. The findings results is shown below. So maximum heart rate of 162 beats per minute, average heart rate of 85 beats per minute, minimum at 45. His PVC burden was 24% of total beats, and that's a high PVC burden. The PVCs appeared unifocal, had a left bundle branch block, inferior axis morphology. PVCs occurred mostly in bigeminy and trigeminy, and rare episodes of non-sustained ventricular tachycardia. Again, the patient denies any new change in symptoms since last time. And a TTE was also done, which reported an ejection fraction of 55% and no valvular nor wall motion abnormalities. So the next question is, what is the best initial therapy? And I can go back to the question if you guys want to see it again.
Switch over. You guys, I'm gonna start the poll and then switch over.
Me.
All right, what are the answers here?
Oh, Eric, I think you forgot to share. That's okay.
Go ahead now. Yeah, here we go. So, all
Beautiful.
right, excellent.
Can I just make it?
So here we can't see what the options are though.
Oh, on your Kahoot link?
When it says the shape.
Oh, I see, I see.
So for next one, we got it.
Oh, that's right. Sorry, I got you. Done.
My comment is that I don't know if maybe this is wrong from the history, because I was actually texting and stuff, so I don't know if I got the whole history, but it sounds like we knew that this was probably gonna be PVCs
Mhm.
based on the history.
Yeah.
Competitions. What I usually do is start them on a beta blocker, even before I get the test, to help consolidate, especially if somebody's working 2 jobs, and they have limited resources. To wait to get a test that now you need to start therapy and then retest. It's a little bit of a delay, because I think you can just empirically start the beta blocker from symptoms.
Yeah.
You want them to obviously modify lifestyle, and you can, mag supplement them and do all sorts of things, but I usually do that on the first visit. And I think his blood pressure was a little elevated. He had room for a beta blocker off the get-go. So I would have done that before getting because now you're gonna need to get another monitor on a beta blocker, right? So now you have 2 monitors, and you didn't need that per se. So my idea was to start at the beta blocker up front, and I usually do that.
Great. That's an excellent point. Thank you, Dr. Press. All right, moving along because of time. You want to click into the thing?
Slide again to activate it before.
Very good. All right, so, so we're good. So we talked about that. So basically, a patient with high PVC burden, medical therapy is indicated. Beta blockers are first line along with non-DHPs. But because it's a drug tier level 1 medication, that's typically covered under Medicaid, so that'll be the most affordable option. Right. Skip over to Learning Act because the time. And then this is the next problem. So patient missed the follow-up appointment with cardiology. He was able to follow up a year later with a repeat referral from his PCP. He discloses that he lost his job at the textile factory 6 months ago and has been having difficulties paying his medications co-payment monthly. He mentions that he uses the metoprolol succinate on an as-needed basis to avoid refilling medication so frequently. He still has palpitations, has only been using medications when symptoms arise. Recently, he reported some symptoms of shortness of breath, not being able to keep up at work. He fears losing his job as this would put a financial strain on him and his family. He states 2 months ago, he has been having difficulty breathing and he exerts himself and has some bilateral or extremity swelling. So on exam, again, pitting edema, JVP at 10, mild biobasilar prackles, blood pressure is still hypertensive, heart rates are within normal limits. We did get a repeat TTE, again, that showed an EF of 30%, increased left ventricular size with normal wall thickness, moderate global hypokinesis, mild to moderate mitral regurg, otherwise normal RV and systolic function, no pericardial effusion, and the 12 lead at that time did catch frequent PVCs with a heart rate at 82 beats per minute. So what is the best next step for definitive treatment of this patient's condition? This is my last question. Thanks, Chris.
We're gonna see a spread. We'll see.
Oh, I'm curious. Oh, great. Awesome. You can resume. Thank you, sir.
That's a future electrophysiologist.
All righty. Thank you, sir. Perfect. So yeah, most of you guys got it spot on. So it'll be E, so referred for catheter ablation.
Why is that the correct answer if he wasn't on medical therapy every day and he was taking it as needed? Like, why would you jump to an ablation?
Yes, so because the patient is now presented with symptomatic PVC-induced cardiomyopathy.
Yeah, but,
Guys, go ahead, Dr. First.
even without being on medical therapy, you would refer to ablation?
Well, I think the key question here is definitive.
Yeah.
GDMT by all means, I think would be,
Yeah, which,
I think we all agree that GDMT would be indicated by all means.
Yeah.
You know, but you know, at least this is definitely, there's a definite connection with poorly controlled PVCs and cardiomyopathy. And I think this is the issue about guidelines as well as socioeconomic issues. You know, the question about what is best for a non-inherent patient, like a non-judgmentally non-inherent patient, you know, like what would be the best if you have an obvious cause. And, you know, and then when we were going over this question, I think even talking with Jim about this, you know, it's very, I'm sure the access is very scattershot throughout the country. Thankfully, LA County, we have EP divisions that are able to do this for Medicaid or uninsured patients. But I think ultimately the question then is, if the question is GDMT, but already a guy could not stick onto one agent, and you know this is a high burden, what would be the most like cost-effective, long, you know, long-lasting therapy that you could intervene upon? Again, you know, we're not saying this is the you know, the gold standard of what to do, but these are just some questions that are meant to generate, well, what are the best ways to approach these unusual situations if they can't adhere to GDMT from that standpoint?
Yeah.
So, and there is room that if PVC data does, you know, cause, you know, the likelihood of response EF improvement definitely is very significant. So I think someone was wanting to weigh in.
Yeah, it seems like you're assuming that he's going to be non-compliant with medications. I mean, I think Dr. Kalfan is right. I mean, if he would be compliant and if his EF improves and then his PVCs go away, then you avoid a procedure.
Yeah, and you're at risk with the risks, right? I mean, you're taking a guy who's not on medical therapy, below EF, and you're doing a catheter ablation. So what are you going to do after ablation? Is he not going to be, if he's not going to be on medical therapy? Yes, you're right that he has a PVC-induced cardiomyopathy and there's benefit in ablation, but I would think that even any electrophysiologist wouldn't just say, I'm just going to ablate him without being on a beta blocker. Most people would put them on a beta blocker.
Right. But the question, but then the key stem is definitive therapy. The question here is definitive. I think none of us would disagree about GDMT. That by all means is indication. But there's a lot of hints in I guess in the story here. He has a lot of financial stress. He wants to keep his job. Already he couldn't stay on one pill already with his prior occupation. Again, it's not so much compliance, it's more of an issue of other social economic issues influencing his ability. Now, like I said, we know that obviously there's a concern about cost, right? But at the same time, the issue is what would be the longer cost benefit of an effective ablation versus continued hospitalizations from inability to stay on GDMT. I think, again, we don't have an absolute answer for that. But again, this is meant to generate a discussion of what is indicated for these kinds of patients. And unfortunately, that may not be able to stay on GDMT or medical therapy all the time. So, and unfortunately, as Ola will say, we don't have any data about this, especially in vulnerable populations.
Yes, when looking at disparity issues, when we look specifically at the arrhythmias, like I'm doing a separate study on VT ablation on patients with arrhythmias and coming in with different like health equity disparities, it's shown that basically people who come in from certain backgrounds are probably less likely to get ablation. And obviously, we can say that's fairly obvious. Medicare issues, trusting medical professionals. There's a lot of different components that cause those limitations. And again, in this situation, We do know like while goal-directed therapy should be initiated, again, it's like doing the due diligence in this patient. We didn't want to assume because this patient doesn't have the resources, then we shouldn't at least attempt to refer the patient for catheter ablation to at least see the electrophysiologist to have that discussion.
Yeah, I agree.
Yeah.
Prefer.
Yeah.
But that I understand, like, I didn't see I thought you meant just catheter, like a blade.
No, just-
Like,
It's just
you
due
can't just
diligence.
replace the guy.
Right. You know, even if the patient, let's just say, had 40% burden, and EF was normal, and they're still symptomatic, and we get a little young, even house staff who have high PVC burdens. And the question is, they want to be on a beta blocker for like 30, 40 years,
That's a personal question. Like,
Yes,
would
question.
you want to have an ablation with risks, or would you rather stay on the medication?
Exactly.
Titrate, take 50 BID, take 75 BID, and then maybe you don't need anything, and then you didn't have a complication, which honestly could have hurt him more. There's a complication that he's out of work, can't work, because now he has goes into heart block and needs a pacemaker. You know what I mean? There's other things that happen down the line.
And that'll be the conversation. So yeah.
That's the thing about counseling about strategies is stay adherent. There's a guy who obviously is physically very active, and now he's getting heart failure and he can't work. So what is one, this is the thing, is what is the ways to really at least reverse an obvious cause while you put them on medical therapy. So, right. So, yeah, go ahead.
Yeah, that's pretty much it. I don't want to belabor the point because we have other presenters as well. So I'll go ahead and pass the baton over to.
All right, great. Thank you, Omid. Thank you.
All right, guys. I'm controlling it. I didn't realize that. All right, so this is a case on identification of social disparities and health inequities in African American Black patients diagnosed with HER2 positive breast cancer. We're on the case with Dr. Chen, Dr. Deswal, and Dr. Yang here. So these are the learning objectives. Case presentation. So we have a 66-year-old postmenopausal African American Black female with a history of hypertension, chronic kidney stage 2, recently diagnosed with breast cancer, who's coming in for cardiac evaluation prior to treatment. She was diagnosed 1 week ago with stage 3A breast cancer. And as you can see, she's HER2 positive with an immunohistochemistry 3+. So she is being, per the oncologist, considered for HER2 directed neoadjuvant therapy with trastuzumab, docetaxel, and pertuzumab. In terms of cardiac specific history, so she's asymptomatic, no history of chest pain or heart failure. She walks 2 to 3 miles a day, can go up 2 flights of stairs. For her hypertension, she's on amlodipine 5 milligrams. Her home blood pressures range between 140 to 150 systolic. She has a family history of hypertension and hyperlipidemia, no smoking, drinking, recreational drugs, and she has a sedentary job, works as a journalist. This is her physical exam. Things to note is her blood pressure elevated to 172/92, and her BMI is calculated to be 32. In the clinic, an EKG is done, normal sinus rhythm with criteria for left ventricular hypertrophy, and she has an echocardiogram, EF of 50 to 55%. By Simpson's, mild concentric LVH, no other abnormalities, and a longitudinal strain GLS was done. That was negative 21%. So question number 1, given this patient's new diagnosis and plan for HER2 directed therapy, our oncologist asks you if there is any additional cardiac workup or medical therapy required prior to initiating her cancer therapy. What is the most appropriate next step? Do nothing and proceed with cancer therapy. Increase amlodipine, start lisinopril, discontinue amlodipine and start lisinopril, or start the hydralazine isosorbide dinitrate combo.
I think I'm really sorry because the things are not, we had a little bit of worry. Why don't we just kind of have an open discussion here? Forget the polling, but
I'll put it in the chat too.
yeah, you can put it in the chat as well if you guys want to suggest your questions here. So.
Only risk factor right now is just uncontrolled hypertension.
Right. Uncontrolled hypertension, CKD. So. I would say what you say?
It seems like ACE inhibitor is reasonable, renal protective, cardioprotective.
Yeah. Okay. I mean, that does have some not great RCT data, but definitely something worth, that I think can, that has some data in lowering the risk of of cardiotoxicity. But really the goal here really, again, is really what agents are testing what you know and what is best for a blood pressure control in this particular patient, as well as what she's about to get. And I will say that hypertension definitely is a risk factor for cardiotoxicity too. So, all right, go ahead.
So we agree, start lisinopril. So hypertension specifically has been shown to be an independent predictor of difference in survival between African-American Black patients compared to their Caucasian counterparts. HER2-directed therapies by themselves also cause hypertension. And because of her high risk of CPR-CD with the risk factors that you mentioned and the uncontrolled hypertension, trusting lisinopril, amlodipine shouldn't be discontinued because it's per the 2017 AHA guidelines, it's a great agent for that population. And given there's no history of heart failure, the hydralazine isosorbide dinitrate combo is not indicated. Cardiovascular disease disproportionately affects racial minorities, and a new cancer diagnosis, such as in this patient, amplifies that disparity. And socioeconomic barriers negatively impact that therapy. Many with new cancer diagnosis have undiagnosed and undertreated cardiovascular disease, and it's on us to sort of look for these and make sure that we get them treated. So when they walk in through the door, thorough cardiac evaluation and risk assessment are key for care of these patients. This is from one of the papers that published a sort of a risk assessment scoring. And this is what they recommend in terms of baseline CV risk assessment. Each patient is individualized, so you have to sort of go through these. But it's really important that you sort of investigate each portion of this chart here. So this is actually from that same paper. So as you can see, this is their risk factors that they talk about. However, nowhere in that do they mention anything about the patient's ethnicity, which for African-American Black ethnicity, it's associated with an increased risk of cardiotoxicity and mortality compared to a Caucasian female with the same breast cancer diagnosis.
I mean, the data is very limited because, again, the thing about African-American Black population with breast cancer, as you will talk about, there are higher both cancer and cardiovascular mortality, but at the same time, Black women are more likely to get triple negative, which is usually the more high, the worst prognostic factor. At the same time, there also is a higher signal of event rates pre, during, and after. And anti-HER2, there was a Medicare SEER kind of risk score assessment that's only one study in JAHA, where they did say that African-American Black race was also considered a risk factor for additional cardiotoxicity with cardiac dysfunction from that standpoint. But again, these are all retrospective, like large-scale studies as opposed to actually looking specifically at. And most unfortunately of our cardioprotective randomized control trials, ethnicity is not identified, especially in European cohorts as well too.
So like Lua mentioned, specific risk factors, uncontrolled hypertension, CKD, elevated BMI, and actually low normal LVEF is also considered a risk factor. So she's at high risk for cancer therapy related cardiotoxicity, especially given the use of two HER2 directed therapies that they're going to use. So the patient starts on lisinopril while continuing to keep a blood pressure log at home. Her BMP was noted to be 49. Given the above, her oncologist starts her on the cancer treatment regimen outlined. Based on the current recommendations, what is the appropriate timeline of monitoring in this patient? You could say return as needed, no set timeline, get echocardiogram and blood pressure checks every 3 months. Repeat echocardiogram in 1 month if it's normal, only get it if she develops symptoms. Do a 1-year follow-up and only do echocardiogram if the patient becomes symptomatic, or echocardiogram and every 6 months with global longitudinal strain.
Chris, I assume you're going to be doing this soon in a couple of weeks with your new practice. What would your
The answers are.
the answers from working with clinic with me, but
I think the big thing is, monitoring the blood pressure, because I think, as we talked about before, is a risk factor for developing cancer therapy related cardiac toxicity. And then while you're on HER2 therapy, I think it's pretty frequent checks with strain imaging. So the answer is going to be B. So if like the other options like E, I don't think every 6 months is close enough in terms of monitoring this type of cardiac.
Askable by a future cardio-oncologist. So blood pressure monitoring with echocardiogram every 3 months. So HER2-directed therapies can cause subclinical left ventricular dysfunction. So the FDA on their website actually recommends LVEF measurement at baseline and then every 3 months during and upon completion of trastuzumab. If you need to hold the anti-HER2, they recommend LVEF measurement at 4-week intervals for significant LV cardiac dysfunction. All of this data is based on back in the day when they did a sequential therapy of anthracycline and HER2 with their therapies. And this is sort of not the guideline currently. So much of our data is not just on anti-HER2 monotherapy or what this patient is having specifically. Frequent visits are recommended for evaluation of hypertension, given that she's at high risk for a cancer therapy-related cardiotoxicity. And during each visit, it's paramount that you check for signs and symptoms of heart failure, because manifestations of those signs should trigger a talk with oncology in terms of how to move forward with the cancer therapy. So halfway through her treatment during a routine visit, the patient is noted to have a decline in ejection fraction to 40% with a global longitudinal strain of -15%. When seen in clinic, the patient denies any symptoms of orthopnea, PND, or lower extremity swelling, and her functional capacity remains the same. Her BP logs are showing that her BPs are still elevated, 140s to 150 systolic. After discussing the results, her oncologist contacts you to ask if you should stop the therapy and await recommendation. So what are you going to tell the oncologist? Are you going to say recommend stopping the HER2 and repeat an echo in 4 weeks and resume if improved? Up-titrate the lisinopril and initiate carvedilol to optimize therapy, continue HER2-directed therapy with close monitoring, permanent discontinuation of HER2-directed therapies due to the LVEF decline, continue HER2-directed therapies with no change, or start dexrazosan.
So I can tell you historically, several years ago, probably C would probably be, or at least A would be sort of the, the standard practice. Remember, this patient really, she's not symptomatic. This is just like imaging.
But she technically does have.
Well, she has cardiovascular. There's yeah. Assuming all the studies are of good quality, there is an EF drop.
Yeah.
So the question then is, what should you do?
Well, this was your patient in your cardiovascular center. That somehow slipped past my clinic.
As I'm texting you from clinic, what do I do?
By the way, this is not a right or wrong. This is a what,
Yeah.
what
I mean, I don't like all of the, she needs,
This is
she
the one
needs
question.
GDMT.
Sure.
And so whatever options have that is probably what you're probably reaching for A. I think some would, I'm sorry, for B, but I think some would say to add meds and pause and repeat echo soon.
So Chris and Omid, do I pause? They're feeling well.
Well, because I think it's funny because she knows what you want to do.
Yeah.
Like,
Yeah, like test taking.
That means you guys.
Eric wants me to choose.
Well, that means at least you guys are paying attention to what I'm doing.
People uncomfortable.
Right. Well, exactly. And the breast oncologist will be uncomfortable, right? But this is the thing, is just that now we have some early phase 1 data that Omid's going to go over. It talks about how, there's associations that if you stop therapy for breast cancer, you're more likely to do worse. And your likelihood of survival at, 5 years plus with stage 3 or below breast cancer is over 90%. So this is considered by all accounts a curable disease state. But if you have to stop for whatever reason, and historically, of course, there's clinical concern for that. But the question is, do you have to stop? Right. So Omid will tell us whether you have to stop or not for an asymptomatic individual.
Yeah, so Louis test taking skills, amazing. So up-titrate lisinopril and initiate correct. So this patient has developed, and it's important to recognize that it's a mild asymptomatic LV dysfunction due to the cancer therapy, and her hypertension is still suboptimally controlled. So when she sees you, she requires treatment of the cardiac dysfunction, the hypertension, as well as the discussion with oncology. So what's important is that you have to sort of multidisciplinary talk to them and weigh benefits of HER2-directed therapies in someone with stage 3A breast cancer versus risk of developing clinical heart failure from continuing these medications. So just a word on dextrose, and I always have trouble saying it. It's an FDA-approved medication with a narrow indication for treatment of anthracycline-mediated cardiotoxicity. Use is currently restricted for metastatic breast cancer in those who've received more than 300 milligram per meter square of doxorubicin with ongoing doxorubicin-based chemotherapy. So that doesn't really apply to this patient.
Although it has the most actually clinical randomized controlled based evidence of protection against anthracite. So you will bring that up if someone is high risk.
Yeah, so this is a recent study that was done, and the data from the study is always yearly they publish about it. It's called the Scholar trial. It's focused on safety of continuing chemo in patients with left ventricular dysfunction who are on HER2 therapy. It was a phase 1 prospective single arm trial. So, and they focused on patients with stage 1 through 3A breast cancer who could continue on trastuzumab if they have asymptomatic left ventricular ejection fraction between 40% and lower limit of normal, or if their EF dropped by 15% from baseline. And they were titrated on cardioprotective medications, ACE inhibitors and ARBs, or beta blockers. Exclusion was NYHA class 3 to 4, SBP less than 90, or contraindications to go on those medications. And what they focused on is cardiac dose limiting toxicity, which is cardiovascular death, EF dropping less than 40% with heart failure symptoms, or EF of 35%. They had 20 patients in total that were in the trial. So out of the 20 patients that continued, 18 were able to continue and finish up their trastuzumab trial, which was over a year. 2 out of 10 developed cardiac dose-limiting cardiotoxicity. Both of them, their EFs dropped to 28 to 26% with NYHA 3 and 4 symptoms. Upon discontinuation of trastuzumab, all of those two's EFs came back up to 56 and 47% respectively with NYHA class 1 symptoms, and there was no patient deaths. Those are the ACE inhibitors, the ARBs, and the beta blockers that were used. And as you can see in this chart, as these patients continued on their therapy, their EF with cardioprotective medications actually went up.
We're hopefully going to be a site for Scholar 2, which will be a bigger, more like grand scale systems of care randomized trial with this. Whether you wait traditionally, then resume GMT, or start GMT and you keep going through treatment. So, yeah.
Do we do the same thing for anthracycline mediated toxicity? Like, do we use this data or?
You can extrapolate it. I would say that, again, it's really, to me, it's the presence of whether they're clinically in heart failure. And EF that drops 40%, you see it. Usually, most cases happen after treatment. So it's unfortunately most of a post-treatment problem. But trastuzumab tends to occur, especially if you go to centers where they still use anthracyclines. The risk of EF drops are much higher. And the question then becomes, should we really be, like stopping and whatnot? We need to investigate this further. But honestly, from my end, if you're not clinically in heart failure, which was like used as endpoint, small study, obviously, but still, the goal really is to complete treatment. And this and SafeHeart showed that most patients could actually complete their treatment strategy, even with a low EF, low ejection fraction.
Yeah, so then this idea of permissive cardiotoxicity is emerging over the past couple of years, defined as a proactive approach to continuing cancer therapy while mitigating associated cardiotoxicity given the oncologic benefit. And so there's multiple issues in terms of inequities and disparities in care. So someone who you're trying to do permissive cardiotoxicity, they need to be able to go to a cardio-oncologist. They need to have regular follow-up every 3 months with a cardio-oncologist, ideally depending on the scenario. So those are all limitations. And also Scholar, the trial, the 20 patients that were there, like most clinical trials in cardiology, a large portion were Caucasian. So extrapolating the data is sort of a little bit still difficult.
It's important, I think, to highlight this because you have a vulnerable population that has higher incidence of cardiovascular risk factors and with potential higher risk for cancer, which we'll talk about. And really, this is just to emphasize the need to be aggressive in risk factor control, not just for the cardiovascular issues, but for the cancer reason as well, too. So
she's resumed on her cancer therapy. Lisinopril is up titrated, and now she's on Coreg. She takes her BP logs, checks them. They're in the 120s now. She continues to deny any symptoms. So subsequent echo shows an EF of 45% with a GLS of negative 19%. So what's true regarding outcomes in African American Black women compared to Caucasian women?
We should just go straight to the answer.
Yeah, so basically they're at high risk of cardiotoxicity, cardiac and cancer-related deaths. So survival rates are lower in comparison to Caucasian patients in every major type of cancer, with the exception of renal and pancreatic cancer. While socioeconomic factors and inadequate healthcare are definitely factors, some studies have shown that even when you account for these, that the ethnicity may be an independent predictor of poor breast cancer health outcomes. African American Black patients are more likely to present at a more advanced cancer stage, more likely to present with a hormone receptor negative disease at a younger age, and more likely to have a significant risk factors for cancer therapy related cardiotoxicity, such as hypertension and diabetes that are not effectively treated. So in total, I think we should move through this, but in patients that come in with such as this patient, you need to take a thorough history, figure out their risk for CT/RCD, and start close monitoring. Use of HER2 mandates interval echocardiogram. You could use cardioprotective medications for those that develop CT/RCD. And it may be possible, this idea of permissive cardiotoxicity for patients that need the chemo to continue it. And then it's important to recognize, as with the goal of these talks, that African American Black females with breast cancer have survival rates and outcomes that are poorer compared to the Caucasian counterpart, and further research is necessary into all of that. And that's all of us.
Thank you, Omid.
There you go, Chris. All right. I have an interesting thing that I'd like to bring up that hopefully displays some intersection of different topics that we're talking about today. So we have a 60-year-old female who presents with palpitations, decreased exercise tolerance, the history of colon cancer, Graves' disease, and pernicious anemia. She presents after a PCP referred for an abnormal EKG. Symptoms: 3 weeks of palpitations, decreased exercise capacity. She was previously able to exercise quite vigorously, but now gets short of breath with much less. Also had some URI symptoms in the last 2 weeks, and also has some slight blurry vision. In terms of her cancer history, she has moderately differentiated T3N1 adenocarcinoma of the colon with microsatellite instability mutation. That she's about 8 months into her diagnosis. She already had a surgery, right whole hemicolectomy. She was treated with capecitabine and oxaliplatin, and then she's also been on nivolumab for the last 3 months. The last dose she got was 1 month ago. She works as an electrical engineer around the area. She's divorced and has one adult child. Here is her initial exam. It's pertinent for tachycardia, normal tension, and not too much else besides tachycardia, no JVP, no lower extremity edema. She's otherwise looking okay. The EKG, however, shows that she has ventricular tachycardia with diffuse ST elevations, and her initial troponin I, not high sensitive troponin I, is 30. A TT was done urgently, which showed global hypokinesis and EF of 30 to 35%. Other things that she said, she was fully vaccinated against COVID-19. Interestingly, a urine tox was ordered, and it was actually positive for cocaine. Other laboratory results come back. Influenza IgG and IgM are positive. And when asked about the cocaine use, she said, at a social event about a week before, she reported using a single episode of cocaine, and it was the first time she ever used it. So the pertinent positives: the influenza laboratory, the cocaine usage, and her cancer history. Okay, first question: what is the most accurate statement regarding likelihood of myocardial infarction in this patient? Timing of reported cocaine usage is consistent with cocaine-associated myocardial infarction. Myocardial infarction is the most common cause of chest pain in patients in the ED with cocaine. And white patients and black patients black patients will have a lower rate of coronary catheterization revascularization in the setting of ACS with cocaine. And that influenza does not. Thoughts? Yeah, it's kind of the way it's worded is kind of leading. But yeah, there's been studies that when you have similar patients presenting with concern for ACS, black patients, for whichever reason, have lower rates of coronary catheterization and revascularization. And part of it might be, inherent biases on behalf of the healthcare system. Other questions, so usually cocaine usage is immediately associated with cocaine-associated cardiovascular disease. And so the time frame doesn't really quite work out. And actually, people who present with chest pain with cocaine usage, only about less than 10% of them are actually presenting with ACS. Other than do not have any evidence of ACS. And I think there was a New England Journal of Medicine article about 5-6 years ago that showed that influenza infection increases the risk of myocardial infarction by several-fold. Okay, what's the next best step for workup or treatment? A is angiogram. B, medical therapy alone without angiogram due to risk of unclear adherence to DAPT. Start high-dose steroids for myocarditis, do a cardiac MR, or do a myocardial biopsy.
She had ST elevation.
ST elevations, troponin is 30.
Okay.
Yeah. So I think the thing is that, you have to rule out ACS first. She has all the signs of STEMI. She has a really high trope. Even if her, chest pain story isn't that great, we have to rule out that. So the question for the answer for B is to point out that there was some thought that cocaine usage would imply that you shouldn't take them to the cath lab, or that to test whether, if you think that because they're using cocaine that they would be inherently unreliable. So that was the point of that question. And then C through E would be appropriate once you if you decide they have myocarditis and you also excluded ACS.
Question.
Mm-hmm. Yeah.
Are you using the echo? Because initially when I saw the elevations and then she had this influenza, the markers, IgM, IgG,
Yeah.
I was thinking maybe like myocarditis.
Sure. Yeah.
So is it the global? I think it was not a hypoperfusion and
Yeah.
is that what led you to think like ACS picture versus myocarditis?
Yeah, I think that's a really good question and a point that's worth bringing up, because I think you're weighing what you actually think is the most likely diagnosis and the things you absolutely can't miss. And so if we're thinking, oh, this could be STEMI, even if you're thinking, well, this doesn't quite fit, we actually absolutely have to rule out that, even if it's to exclude it and to actually be able to narrow down on the correct diagnosis. But absolutely, so like diffuse hypokinesis doesn't really fit a wall motion. And then the chest pain story is kind of squirrely. So maybe you don't actually think it's ACS, but you need to put it to rest. Because if you're actually wrong, which you may be, a handful of times, if you see the same patient over and over again, you can't miss it.
Yeah, I mean, we designed this, and again, we knew we were probably going to have some uncomfortable steps. Ultimately, because I suck at Kahoot, and that's why I was hoping to see what the audience would say. But like to say like what you think is going on with this patient, and what do you think is the next best step based on what you think it is. And there's obviously a lot of discussion and talk about which populations usually get tested for drug use and what you think is going on based on this. And in some cases, people might blame the drug use on a myocarditis state. Right now, all the echo and all the data you get, you really can't tell the difference. But the question actually you have to ask yourself, is the timing really consistent if you're really going to blame it on drug use or even viral infections, right? And I certainly think, the best thing still is to rule out acute coronary syndrome. The question is, with some populations, would they act differently, say, oh, you're using drugs? And, we'll just treat you conservatively, from that standpoint. So, yeah.
Yeah, excellent point, though. Okay, so they're taken to the cath lab, only mild non-obstructive disease, without anything else that's abnormal on the angiogram. So now what's the most likely etiology of this patient's issue? It's cocaine? Is it the nivolumab? Is it influenza? Or is it like a toxicity picture?
I think the one that we have to be thinking about soonest is B, because our treatment for that is going to be very different than all the rest. And so, I think that, this patient discussing whether or not starting on steroids, because the rest of them not going to be the same urgency.
Right. And that's the thing. I mean, I think it's actually based off a real case. And we didn't know as much about ICI myocarditis before, but just speaking very openly, the other three were actually more in the forefront at the time of this case presentation. I think based on her labs and her workup on standpoint, and I think this is, a lot of people also basically thought that this was too far out from the checkpoint. but I think a lot of the other things are much less likely and much more rare. And cocaine myocarditis is also even exquisitely even more rare. And it doesn't happen usually like a week after use, and it's usually much like in most like toxicities occur like immediately during use on top of that were the case. And it doesn't behave like that. Let's stand.
Does it happen? Is it like increased risk of more frequent usage or can it happen?
I think it
Yeah,
can,
I don't think we have any data on that. No one really knows what right? And the other question then is also really like, it's a question of, well, are you going to believe certain patients? Or you're not going to believe others based on their timeline, from that standpoint. So, yeah. And they were very open about sort of telling them when they used it, so yeah.
Okay, so underwent cardiac MR, shows myocarditis. So there's LG throughout. A biopsy was also performed, which confirmed the diagnosis of ICI myocarditis. Was treated with high dose methylpred, ATG, and actually she had a much longer hospitalization course, which isn't relevant to this talk, but she eventually did quite well after a long hospitalization. Okay, so which of the following statements is true regarding ICI therapy? So one thing that Eric was pointing out is ICI associated myocarditis does not occur after 3 months of starting ICI therapy. There are no differences between ED visits or inpatient admissions by race by receiving those receiving ICI therapy. Female, gender, Black race are associated with increased risk of cardiovascular complications to ICI therapy. And ICI therapy should be restarted in this patient as soon as possible.
As aggressive as I am, I would not pick the.
Yeah. So I think, in terms of CY, that's correct. There's actually some data that shows that they have increased rates of frequency or increased risk of ICI therapy for both female, gender, and Black race, which for reasons are not understood at this point. So that's definitely something that's been reported in the literature. You can see ICI myocarditis up to about 1 year after starting, but it's mostly going to be clustered in the first 3 months. I think 80% of your myocarditis is in that area. And then in contrast to Omid's case, ICI therapy should not be restarted because this is a case of pulmonary myocarditis. And so there's probably not data for
She's
it.
in remission too.
Right.
She was treated.
And then she's actually not gonna, there's actually doing quite well.
Like VT, cardiogenic shock requiring mechanical support, all of those
Yeah,
factors.
exactly. So, the gender sex difference is still controversial. I think there's a lot of conflicting data. We still don't know. And it also depends on the cancer and which different, things. But I think this is very, this is something we're still trying to understand whether there are sex differences when you check microtoxicity.
Yeah.
But unfortunately, it sounds like there's a signal early that certain, populations unfortunately are still also prone to the same, healthcare biases or issues as well. So, and this just came out a few days ago from Dr. Quinn Capers, who gave the talk here, which was, I think, also asking a very direct and just question about really who do you really target if you're looking, when you're ordering a UTOX to stop heart failure. Again, like most things in Twitter, people like to answer in a virtue signaling era. They always do the right thing, right? But but there were some very good points and salient points, and some people gave some very honest answers based on meth heavy populations and or also some other reasons why they would do it. So still a tough question. So.
Okay, so I won't spend too much time on this because I want to give Leslie plenty of some time. But I think the big point is that this is designed to show where there could be points of potential bias regarding drug use, race, and even points of bias of things like viral myocarditis and gaps of knowledge with other therapies. And so just not to say to make anyone feel bad or to judge anybody, but just to be mindful of implicit biases that affect all of our ability to make adequate judgments for our patients.
Thank you. All right, Leslie, thank you so much for your patience. You can unmute our final special guest from Houston, and go ahead.
Just say next whenever you want to.
Yeah, just next. Yeah, exactly.
Okay, perfect. Thank you so much. Hi, UCLA. I'm Leslie. Thanks for having me. Hi, Dr. Deswell, Dr. Yang, Dr. Ted, who have been my mentors for this. So the goal for this case is really to help introduce what disparity may look like when it comes to the treatment, specifically of AFib in patients with cancer and in rural communities. So mainly we look for two concepts. Number one would be the rural barriers in cardiovascular specialty care. And number two is this concept of pharmacoinequity, that there are factors that make it more difficult for specific patients to get evidence-based medication. On the next slide, our patient, Mr. Leo, is 70 years old with hypertension and type 2 diabetes, recently treated with ascending colon adenocarcinoma. He presents to your primary care clinic to establish care. He resides in a rural area. He enjoys farming. Your clinic is the closest primary care clinic, which is about an hour away from his farm. His cardiologist nearest his farm is about 1.5 hours away. So in pre-op consultation for his colectomy for the ascending colon adenocarcinoma, he was found to have non-valvular AFib. His outpatient anticoagulation was discussed, but he was very hesitant, having witnessed his wife being hospitalized in the ICU while on warfarin for bleeding complications. He also needed to proceed with urgent surgery for his colon cancer. So currently right now he's asymptomatic, no signs of heart failure, no history of stroke. Few things I want to highlight: he didn't finish high school since he had to support his family. He had always had limited financial means, and he is currently retired. So he is now scheduled on the next slide. He's now scheduled for adjuvant chemotherapy with Volfax. His ECG showed episode of AFib with normal ventricular response on his intraoperative ECG. And ECG this visit demonstrate normal sinus rhythm. So his CHA2DS2-VASc is 3 for his age, hypertension, and diabetes. That's puts his stroke risk at 3.2% per year. His risk for major bleeding is relatively low. So in the next slide will be my first question. So, okay, so which of the following is the best to consider? So again, as you go through the answer choices, a recollection, he is scheduled for chemotherapy in the next week. He's back on sinus rhythm. He meets indication for anticoagulation with relatively low bleed risk. So which one of these do you think is the next best step? A, observe for recurrence of AFib. B, anticoagulation. C, start anticoagulation, also cardiology referral, and D, no recommendations as he is going to undergo chemotherapy.
D happens a lot. But is it the right thing? You know? So,
We should do anticoagulation, either B or
What do you guys think?
I think we feel that being cardiologists in this room, they should see a cardiologist and start AC.
So this one's a little bit easy. So we're going to start anticoagulation and do an early cardiology referral. So the main thing I want to highlight with this case is patients with cancer actually have more than twofold risk of AFib-related cardiovascular disease. But they are less likely to receive guideline-directed therapy, and they're also less likely to have anticoagulation prescription refills. So on the next slide, a few of the learning points. So answer choice C is correct. As you guys said, anticoagulation, CARDS referral, early CARDS involvement on the next slide, Eric, is in patients with cancer and AFib is actually associated with higher rates of anticoagulation use, higher likelihood of receiving rhythm control, and reducing the rate of ischemic stroke without increasing bleeding risk. However, the distribution of this healthcare service really differs in rural community. 96%, for example, have access and have used family physician services. 72 have access, have used ED services, but there's only 26% in rural communities who have access to and have use of specialty cardiology care. And this is kind of where the virtual AF clinic studies have come into play, especially in the recent 2 years with our pandemic in rural communities. And it has shown that so far it has use of AF clinic virtually has reduction in AF hospitalization, improvement in the quality of life in terms of symptoms, and also guideline adherence. So choice A, I'm going to just go through the choice A is incorrect, where it just says observation for occurrence of AFib. Although this is reasonable for patients with high bleeding risk, his bleeding risk for our patient is low. And I want to highlight that specifically patients with cancer have high rate of AFib recurrence. during their subsequent cancer treatment. From, just chronic systemic inflammation, they tend to be in conditions that precipitate arrhythmia, like they tend to be more dehydrated, a lot of electrolyte disorders, pain, and tumor mass effect as well. And use of certain targeted therapies, which I specifically want to highlight on the next click. The example of the TKI inhibitor ibrutinib, which typically used in CML cancer and mantle lymphoma. And then B is incorrect, where it's just anticoagulation. I think this plan just recognizes that anticoagulation should be initiated for stroke prevention in the setting of low bleeding risk and CHA2DS2-VASc score of 3. And even just picking this answer choice is an important step, as nearly about 50% of patients with cancer who have high stroke risk or have normal platelet counts actually do not receive anticoagulation. But again, this one doesn't include the favorable AFib outcomes that's associated with early cardiology referral. And lastly, D, where the answer choice where it just says, no, let's wait until we start anticoagulation because the patient is undergoing chemo. So chemo is not a contraindication to anticoagulation. Current chemotherapy has been independently associated with lower odds of applying AFib treatment algorithms to the cancer population. So next, in the next question, I really want to simulate this concept of pharmaco-inequity or caused by barriers that we tend to see with the newer pharmacotherapies. And we see this a lot in Medicare and also when it comes to our private insurance. So Mr. Leo has Medicare insurance, but he does not have a supplemental Medicare plan. Cancer therapies have also stretched his financial resources, and he can only allot $20 per month for his cardiac medications. So in the next slide is my question, which is the best monthly cost summary delineating the pharmaco-inequity in Medicare coverage? So this answer choice is a little bit busy, so I'm going to walk you through it. So each answer choice is divided by only part A and B. And then as you see in the next part, it's like part A and B plus Medicare Part D. And Part D is this Medicare prescription drug benefit. That's an optional government program to help Medicare beneficiaries pay for their prescription drugs. And it kind of just go over, for example, Part A, answer choice A kind of delineates that there's really no difference or no benefit with having Part D as opposed to Part A and B. And then Part B, you can see that there is a benefit when Part D, when patients have Part D, and both a generic and a DOAC have reduction in price. And then C, you also get that reduction for both. Generic is almost the same as our DOACs. And then answer choice D, it's saying that the generic warfarin is more expensive than our DOACs.
I think this is a very educational question for me.
I hope it's C. Something tells me it's like A.
We are, even with Medicare, we are seeing like even with like traditional drugs like apixaban, copays are like through the roof. It's like 300, 400 at least for some plans. I don't know if it's contracting or changing, so even the people who are insured, they have trouble affording some of these medications. So, so Leslie, you want to tell us? Let's go to the next.
Yes, you can go to the next one. So what do you guys, I guess most of you guys are leaning to answer choice B maybe, which is the correct answer. So for this one, I want to highlight with this question that there is that recognition, right, of inequity barriers that still exist in the Medicare coverage, despite the 2019 ACC, AHA, and HRS guideline update recommending DOACs over warfarin for patients with non-valvular AFib and has no contraindication to DOAC. So answer choice B is correct. And a few key points here. It shows that one, with Part D, it helps cover the cost of the prescription drugs, including the DOACs, as reflected by the cost and reduction with Part D in comparison to just A and B alone. And then number two, it really shows, compared to the other answer choices, that warfarin is listed under Tier 1 of Medicare prescription drugs, while DOACs are typically listed under Tier 3. There come into play that pharmaco-inequity, where Tier 1 drugs are generic generic and lowest cost drugs, and tier 3 drugs are more expensive. They usually require pre-authorization from us physicians on the preference decision over why the tier 3 rather than a tier 1 option. So next, that's kind of, and these are actually one thing I want to go over is the drug costs under Medicare and specific private insurance are actually available to us health providers online. On the next slide, Eric, if you go next, I want to just go through GoodRx. Everyone's familiar with it, but one thing I know for warfarin, if you kind of just pick the medication and if you scroll down, and one thing I want to highlight here is sometimes the coverage is only for a specific number of days. So you can pick 30 days. Most of the time, the insurance in Medicare only does like 30 days. And then if you scroll down, you click on the Medicare tab, and you go to the very bottom where it says see my plans resources. See my plans prices. And then on the next slide, this kind of inlet will pop up and it'll show you can actually choose a lot of the different Medicare associated insurance. And for example, this is warfarin, and you see the difference where it's free and $1. And then if you go through Xarelto, you can go next. And then going through Xarelto, we looking at the prices in Medicare. So this, for if without anything, it's about $500. And here it's about $19 after once the patient has reached their deductible. So that's kind of, we see that stark difference in putting warfarin at tier 1 and putting a DOAC into a tier 3, even though the guidelines do recommend DOACs over warfarin for non-valvular AFib. And then next. So this is going to be my last question. A lot of kind of thinking on this one. And this last one will create a model to really show the current AFib care in rural communities. And I think its understanding can help us provide and tailor our AFib care in patients in rural communities. So what this chart, super busy, but if Eric can help me kind of manage with a cursor as I walk you through along the choices. This is really looking at 6 different relationships. So on the first kind of graph where it shows the symptom severity on the x-axis and then the percent lab met on the y, this shows the relationship of how AFib symptoms and age affect the percent of times patients make their scheduled lab appointments. And then this is something I think important to consider with the need for INR checks with warfarin. And then the second row, what I want you to focus on, the x-axis depicts the number of comorbidities. So as you go from left to right, that's the more complex medical patient. And then the y-axis is the this cardiology referral increase or decrease, which is the rate of their PCP referral to the cardiologist. And then on the other relationship is does comorbidity actually increase or decrease, positive or negative relationship to the tendency of their primary care physician to start the patient on anticoagulation. So really for this second row, it's the pattern of their primary care behaviors that we see in the rural communities. And then the third one is what percent of AFib patients really have access to care. And then in the next one where it shows the ED visit, so that's your y-axis. So if they do have access, do they tend to have more ED visit, or if they don't have access, do they tend to have more ED visits? So that's kind of the different relationships for these.
Yeah, I apologize for the title. So basically you're saying what is the pattern in rural communities, right? In terms of.
Yeah, so it's cut off. So it's going to be which set of graphs that you think best models the pattern of AFib care in rural that we tend to see in rural communities.
The VA team says B, and presumably they actually probably see more rural populations than we do.
Yeah.
First referral. So
on the next slide, Eric, I'm just going to tell, so the answer is actually E. So kind of going through that, for the first set of relationship, this is between, symptom severity and percent adherence to lab visits. And of course, as debilitating symptoms like heart failure, fatigue, activity intolerance, that tends to decrease the adherence to traveling for this lab test, especially in rural areas where the average home to lab distance is 10 miles. So that kind of depicts that, which also has, which is also reflected in answer choice B, that the VA answered. And then number 2 is the kind of the relationship between the number of comorbidities and cardiology referral. And actually, actually B was what I thought kind of the instinct, right? That as they get more complex, maybe the primary care physician will tend to need our assistance. But actually studies have shown that the relationship when it comes to relationship between the number of comorbidities and cardiology referral is actually inversely related in rural communities. There's concern with referring complex patients that stems from patients returning with too many medications, which creates problems more so in rural setting when there is a lack of specialty follow-up and managing details of specialty-specific medications that tends to increase the risk of adverse events. And then the relationship between the number of comorbidities and the likelihood of anticoagulation. For B, it depicts that there's really no relationship, but actually there is. There's concern of it's been found that rural primary care physicians have concern for life-threatening bleeding in patients with high fall risk and cognitive impairment, and difficulty with close follow-up imposed by lack of transportation and travel time. And then for between B and E, when you compare them, you guys got it right. The kind of the relationship between, of course, as access of AFib care within a week in the rural communities, only about 25% of them get that care within a week. And because of that, they tend to have higher ED visits. And they use the ED a lot more than their specialty clinic care. And that's it for my learning points. Thank you so much for having me.
Okay. Well, thank you again. I'm sorry we kept you over time, Leslie. And again, we know we're running late and there's a little, I take response. Sorry for the polling snafu, but again, we hope that this, at least for our fellowship and others, we can kind of generate more interest to have a lot more of these case-based discussions, not necessarily just focusing on, knowledge base and care, but also really how we can better deliver it to our patients, addressing our own institutional and personal biases in providing, more, objective and equitable health care as well too. So thank you all for everybody for joining, and congratulations to our presenters, your next step, and thank you again for attending. Great job, Leslie. Thanks so much for doing this.
Thanks, bye, Eric.
Thank you, guys.
Thanks, everyone.
Do a picture of you guys really quickly in front of the title, really quick, including Leslie on the virtual background.
Okay, bye.
Are there any questions from the audience?
Yeah, everyone's like ready to like, yeah, no, I appreciate it.
I know, I'm so sorry I went over.
We were the one that were late, so I appreciate it. Where's my mouse? Where's the mouse? Go back to
You in the background, right?
the title on the background.
Okay, so we probably.
Yeah. Where's the mouse?